with the lab on the knee joint is going to supposed to help you to remember the things I talked about this morning. All right. So first of all, we mentioned that the knee joint is a sort of modified hinge joint. A hinge joint is where, literally like a hinge, it only has movement in one plane, and that's usually flexion and extension. But in the knee joint, when it's flexed, as I showed you in the lecture this morning, there is a little internal and external rotation of the leg on the, so when it's in full flexion, when it's fully extended and it's flexed, right, okay? When it's flexed now, there is a little movement of the tibia on the fibula like that, medial rotation and lateral rotation, but not when it's extended. When it's extended, the knee has to serve to support you. So it's like a pillar, like you're standing on a pillar. There's no movement there. So let's just go over the different articulating surfaces. Remember I said also, it's a compound joint. That means it has more than 2 bones involved. And the fibula is not one of them. It's the patella, the condyles of the femur, and the condyles of the tibia. So we're going to start with the femoral condyles first, and then we're going to put them together. This is a pretty small bone, right? I have a much bigger one here to show you also, right? Okay. So bones vary a lot in size. This is probably a very thin female, small female. And if we look, we can see this is lateral here, and this is medial. But you don't need that to tell you which is the end of the femur. Because as we said this morning, you see the high patellar buttress on the lateral condyle of the femur here. So, as I say, a condyle is just an expansion of the end of the bone, and it takes an articular facet. What we're seeing here is hyaline cartilage. And this area we're seeing right here, right, this area is for the patella. That's the patella articulating area. And as you can see, there's much more of it on the lateral condyle than on the medial condyle. And I'm going to show you the patella in a while. Then we come to the rest of the condyle, which is now 2 separate areas. Same condyles, but the articulating areas are separated by this notch. And this notch is called the interarticular notch. The interarticular notch. And now we're going to look at the difference in the articulating surfaces of the lateral condyle and the medial condyle. And we can see here that the lateral condyle starts its articulating surface from here. And it just goes around back to this area. So it's much shorter and it's sort of rounder. You might agree with that. All right? Then the medial condyle, which starts its articulating surface, that is articulating surface for the tibial condyle that I spoke about this morning, right? Much further forward here. So it's longer and narrow. Longer and narrow. All right, so that's the femoral side. And remember that that notch is where it's occupied by the cruciate ligaments. When we come, I'll just put the tibia with it and show you. If we look at the patella, we can see that the patella here has this is the posterior surface of the patella. It has a vertical ridge, and I'm certain everyone can see that this is a smaller, right? Okay, that would be the medial articular surface is much smaller than this area, right? So the lateral articular surface of the patella, right, is bigger, and that's because it has it's going to articulate with a bigger area on the lateral condyle of the femur. So this is the patellofemoral joint. The patellofemoral joint, right? This area is just for the patella, right, on the femoral condyles, both femoral condyles, whereby posteriorly is just on the medial and lateral condyles. Sorry, the medial and lateral condyles articulated surface posteriorly for the tibia is separate, whereby anteriorly they are joined for the patella. All right. So we come to so remember, I'm going to be showing you the real joints in a while, just starting with the bones, right? The patella, as I say, is heart-shaped, right? And we have the upper border here, right, in which the quadriceps expansion gets inserted. And we can see the apex down here, just like the apex of the heart. I know you haven't done cardiovasculars yet. That's for next semester, right? But this is the apex of the patella, and this is attached now to the patella, to the patellar ligament, right? And not tendon, patellar ligament. So coming from the quadriceps, I'm going to show you in the wet specimen, quadriceps expansion, and from the apex of the patella to the patellar ligament. That gets inserted right at this point here, which is the tibial tuberosity, which I had a bone without this tendon on, but it's attached to the tibia, but it ends in the tuberosity right here. All right, now we come to the articulating surface for the patella, for the tibia. All right, Jordan, you have rain on your end also, eh? All right, that's in Jamaica, right? Jordan Jones. Our volume, you want me to turn up my volume here, Jordan?
No, it was asking.
Oh, I see. Okay.
So I was telling him to try.
Okay. All right. Okay, so let's come to the tibia. Right? We call this, sorry. Come on. Yeah? We call this the tibial plateau, right? In clinical medicine. We just call them the tibial condyles in anatomy. All right, okay? But as you can see, it's like a plateau. All right? And literally, as I was saying this morning, oriented for the ligaments, the femur is going to drop off of the tibia. All right, okay? So the main strength of the knee joint is the ligaments. So if we look here now, we can see this is, let's orientate ourselves. This is lateral. This is where the fibula is. And we're also here, this is a superior tibiofibular joint, which I'm not going to be getting into today. All right, okay? And we have an inferior tibiofibular joint down here. This is a syndesmosis. Right? The syndesmosis is that there's no movement. Right? This is two cartilages on the tibia and fibula connected by anterior and posterior tibiofibular ligament. But you'll do that with the ankle joint with occipitodentally. Right? Here, this one is a synovial joint, right, between here and here. But again, there's minimal movement there, right? Probably just a little, but very, very minimal movement. Remember that the lower limb is made for support and propulsion, whereby the upper limb is for mobility. So the elbow joint is very mobile, but we don't expect these two bones to be mobile at all. They have to maintain the body weight. So these two joints, this joint has no movement at all. The inferior tibiofibular joint, this one does. So we're lateral here. All right, so lateral, we expect the lateral to be smaller, right? Because the facet that we saw on the femur, lateral, the This is the lateral here. So there's a smaller articular facet that's going to fit this smaller area here. And as you can see, it's more circular. Right? Now, you're not seeing the menisci here. The menisci are not here. This is just the hyaline cartilage. Whereby, for the medial, you're seeing a longer, narrow, articulating facet. Right? The menisci are going to sit on this. And I'm going to show you two menisci that are here that they're dried, but still, we're going to show them to you. All right, okay? Now, between the medial condyle of the tibia and the lateral condyle is the intercondylar eminence. Sorry. And as you can see, move it too much. Yeah. As you can see, it's not much of an eminence, not much of an eminence at all. But if you look, you'll see a little area here, a raised area here. That raised area is called the medial intercondylar tubercle. And this little raised area here is called the lateral intercondylar tubercle. And between here, now we can put it like this. So, I'll leave it alone probably. You'll see it better, I don't know. Not really, but I think I have to hold on to it. All right, try and keep it firm for you. All right, okay? All right, so remember, this is medial, this is lateral. All right, so let me just show you the menisci, right, dried, and then I'm going to show you a picture of what this should look like. All right, so this is a much bigger bone, This looks like a giant almost, All right, okay, yeah, pretty big femur this, All right, so you know the parts of the femur, the head, the neck, anterior here is the intertrochanteric line. This is the greater trochanter. This is the lesser trochanter. This is the intertrochanteric line. This is the intertrochanteric crest. But I'm not here to teach you about this end today. I'm here to teach you this part. All right, so this is the lateral. So if we look again, we see the lateral. Right, you see the patella, the lateral patella buttress here. All right, okay, so you can tell because it's higher than this side. This is the patella articulation, and here is the medial. This is the medial condyle, femoral condyle for the tibia. And you can see how long this is, whereby this one starts here and is shorter and smaller and rounder. All right, okay? But coming back to this here.
Hold it back up.
It's a pretty dry, this is a dry specimen, but we can see here, this is what the meniscus looks like, but it's usually, let me show you exactly what it usually, what it really looks like, and then compare it to what that dry specimen has. All right, so we showed you this morning. All right, okay, this here, you can see this is the medial meniscus, and you can see it's longer, and this area is narrow, and this area here is more smaller and circular, and this is the lateral meniscus. All right, okay, so the medial meniscus here. All right, but you can see what they look like here. Right, they've dried out now. This is fiber cartilage. Right, okay, and very rarely you see them on a specimen. Right, okay, very rarely you see them on a dry specimen. So this is the lateral, which is about 4/5 of a circle. You can see that, about 4/5 of a circle. Right, about 4/5 of a circle. And the anterior horn is inserted here, and the posterior horn is inserted here. All in the intertubercular eminence. Whereby we look at the lateral now, it's much longer, narrow, right, okay, right, and it's about a half of a circle, not 4/5 like this one, about half of a circle, And the anterior horn will be attached here, and the posterior horn will be attached posteriorly here. All right? So, you can, okay? Now, the horns attached here, and then these just lie. They just lie on the articulated surface. Right? But the capsule, this is a bit of the capsule right here. Right? So a bit of the capsule is right there, dried. Right? There are some fine attachments between the edges of the meniscus and the capsule. Right? It's dried out now, but it's right? I can't show you in a wet specimen there. I'll have to destroy the whole knee to show you, okay? Right? Those are called the coronary ligaments. They're pretty fine, right? Okay, between the edge of the meniscus and the capsule. All right, okay? All right? So as you can see. Just a second. All right. So in the interarticular eminence, we've seen the attachment of 4 structures, right? Okay, the anterior horn of the lateral meniscus and the posterior horn of the lateral meniscus, the anterior horn of the medial meniscus, posterior horn of the lateral lateral meniscus and medial meniscus here. Now we have 2 other things that attach here, and everybody can take a look here and see how this big ligament we see right here is dried up now, and this is the posterior cruciate. This is the posterior cruciate here. All of this here, right, is attached right at the most posterior part of the intercondylar eminence. The anterior is attached between the anterior horn of the lateral meniscus and the anterior horn of the medial meniscus. This will be the anterior, where the anterior cruciate will be attached, about here. So those 6 things, right? Okay?
Shani, why you don't zoom in a little more on it?
Trying to get
yeah, zoom in a little more on it. Yeah, zoom in a little more. Yeah, wow, beautiful.
Right, okay. All right.
Perfect. You got
good. Perfect. That's nice. That's okay. Yeah, when I put it like that, okay. Thank you. All right, so anterior, posterior horn, right, okay, of the lateral meniscus, anterior, posterior horn of the medial meniscus. Posterior cruciate and anterior cruciate will be right here. Now, let us see where they're inserted. Come to this one. So, go right in here again for me. Good. So, the posterior cruciate occupies this whole area, right, at the posterior part of the intercondylar eminence. And it's going to go, remember we said this morning, P is going to go, PM, the best time of the day, right, okay? So this is going to go right to here. It's big and thick, and it gets inserted right into the medial aspect of the medial condyle, okay? And the anterior now, you can actually see where the anterior is attached, comes off from right here, that area, and that's going to go, right, okay? In this direction now, to the medial aspect, right at this point here of the lateral condyle. Right, and those are the 2 cruciate ligaments. All right. Now, when it comes to the lateral collateral ligaments, now they are going to be attached. All right. So on each femoral condyle, right, we have an epicondyle. So right about here on the lateral condyle, we have an epicondyle, right? And that goes from, that lateral ligament will go from this point, what's the lateral? Fibular collateral ligament will go from the epicondyle here, right, to this part of the this bit here, of the fibula, right? Not here, this is the styloid process, right, which is the highest point. And that's where the arcuate popliteal ligament comes from. This is where the lateral collateral ligament is inserted, and the biceps femoris muscle gets inserted all the way here. All right? Now, there are two other things you need to see on the lateral condyle here. All right?
Sir.
Lateral condyle of the femur.
Sir? Hello?
Remember I said this morning that there is a soleal line on the back of the tibia, right along here. Right? Well, the popliteus muscle arises here, then it goes into the capsule right at this point, and it's going to go around, right? Not the right bone for it, right? Different bone. Going to go around, right? Okay, right? Going to come this way, and it's going to run in this groove here, and attached to a popliteus. So on the lateral arm, the lateral arm condyle of the femur here, right? This is for the lateral, and this groove here is for the popliteus tendon, which gets inserted right at this point. Where you see that those fibers there? That's where the popliteus tendon is. The third thing you find on the condyle is the gastrocnemius. The gastrocnemius head on the lateral condyle. The lateral head of the gastrocnemius is going to arise right here. So the three things on the condyles, on the lateral condyle, is the lateral head of the gastrocnemius, the lateral or fibular collateral ligament, and the popliteus tendon. Right? Whereby on the medial condyle now of the femur, we're going to find here, right? This is the epicondyle here. So we're going to have a broader tibial collateral ligament running from here to about this area. Over the lateral side, okay, let's go over the lateral side. I'm going to show you the wet specimen in a little while, right, okay? But the three attachments, remember that the collateral ligament is one. So on this side is the fibular collateral ligament. Next thing is that the gastrocnemius, which I'm going to show you, has a lateral head attached to it, arising from it. And then the third one is the insertion of the popliteus tendon, popliteus muscle, which arises from the back of the tibia. On the lateral head, you got one right away. That's the tibial collateral ligament, right? Okay, or medial collateral ligament. Okay. Tibial collateral ligament right here. Then we have the medial head of the gastrocnemius would be right here. Right, you get two. And the third one, you have done the side. So where, could somebody tell me where their Dr. Magnus is inserted? Ariel, where's their Dr. Magnus inserted? Anybody can tell me? Remember that Dr. Magnus has two parts to it, eh? Well, yes, part of it on the linear aspera of the tibia, of the femur, and this is the linear aspera here, right? Okay. But remember, it has a adductor head, right, and a condylar head. Part of it comes from the ischial tuberosity. So we have a area here called the adductor tubercle. Right? If we look here now on the medial side, we can see the adductor tubercle. Let's go right here. You can see the adductor tubercle here. That's where the adductor magnus, the part of the adductor magnus that arises from the ischial tuberosity. Right? Okay. Right. That is called the condylar head, and that's the hamstring part of the adductor magnus. Right? It's attached here. Whereby inserted, whereby the adductor part is inserted in the linear aspera behind here. right? The linea aspera. Here's the medial lip of the linea aspera, the lateral lip of the linea aspera. By the way, as we come up here, this is the lateral supracondylar ridge, and this is the medial supracondylar ridge. All right? So those are some of the things we need to know. All right, okay, so let us come back to the bones. Let us just go through a couple of these see if you remember much about what was taught to you on the thigh and the ligaments and the muscles that are attached. All right, okay, so this is we're not going to go look at the joint as yet, but here we're looking at the anterior aspect of the thigh. All right? And I don't know if anybody knows this is lateral. I don't know if anybody knows what is this part of the fascia lata called. Anybody can tell me? This part, this thick band of the fascia lata here laterally. Can anybody tell me what it is called? Tensor, go ahead, from Brianna. Tensor fascia lata. Tensor fascia lata. Okay, Brianna, what are the two muscles? Right? No, it's called the iliotibial tract. Sorry, it's called the iliotibial tract. You took me off it a bit there. But the muscle that's inserted into it, two muscles are inserted into it, right? Tensor fascia lata, and what's the other one? Gluteus maximus. Very good, Amani. You're doing very well. You're doing very well, okay? Those two are up from the gluteal region. And this, remember when I told you, when I showed you that picture of Mr. Bolt on the block, right? When he's on the starting block and you see those two bands on the side of his leg. This one is the tensor fascia lata, and this one is the bicep femoris tendon. All right, so it's the bicep femoris tendon here, and this is the tensor fascia lata. Now, who is going to tell me where the tensor fascia lata, not the tensor fascia lata, but this is the iliotibial tract, and this is the biceps femoris tendon. Who is going to tell me where the iliotibial tract is inserted? Gordy's tubercle. Very good. Who's that? Sidney Johnson. Sidney Johnson. Let me show you Gordy's tubercle. It comes in every exam. Right? Tibial tuberosity is right here. So this is the front of the tibia. This is a plastic bone. This is the tibial tuberosity here, and this is Gerdy's tubercle. This big area here is Gerdy's tubercle. All right, medially. Sorry, laterally. So the tensor fascia lata is going to come down here and get inserted right into Gerdy's tubercle right here. All right? That's very good. Amani, you did very well, right? Okay? You knew the two muscles that insert into the iliotibial tract, and you knew where it is inserted. Very good. On this bone here, this is Gerdy's tubercle. All right? Okay, so there. Tibial tuberosity here, Gerdy's tubercle here. All right? So everybody knows when Mr. Bolt is on the starting block and he's ready to go. You look at the lateral aspect of his leg. You see the iliotibial tract there, and you see the biceps femoris tendon back here. All right? Okay, let's come to the medial side now and see what sort of muscles. Well, first of all, let us look at the quadriceps expansion up here. See if we can find it. So let's move the iliotibial tract out of the way, and we can look and see where. Anybody can tell me? You can see three parts of the muscle here, right? What is this part of the muscle? We're laterally. This muscle. Anybody can tell me what this is? Vastus lateralis. Very good. Very good, Kareem. You've been answering all my questions. All right, and so this one would be on the medial side. But you can see that. All right, remember this morning I said that there are three things that prevent the patella from slipping over the side. All right, anybody remember that from the lecture this morning? Three things that prevent the patella from dislocating. The buttress, the high patella buttress. Yeah, that's cruciate ligaments, but not necessarily. We're talking about prevent the patella from slipping over. Right? Remember we said that the lower fibers of the vastus lateralis, vastus medialis, they are running horizontally, right here like this, and they're going into the side of the patella. You can see that right there. Whereby the lateralis is not like that, going down, but these lower fibers are running horizontally, right? Okay, and they're going into the patella, right? Okay. And the third thing is that there are some retinacular fibers that run from the side of the patella and the patella ligament that go into the bone, right here. So these two lines, right, okay, going down to the tibial tuberosity, they are sometimes called the retinacular lines because that's where the retinacular fibers come in from the patella and from the patella ligament, right? They also help to keep the patella secure and prevent it from slipping over the side. All right. So let's come now to that's the vastus medialis. What do you think we'll be seeing here? Huh? Right, that's the rectus femoris, and what will be under the rectus femoris? Brittany. What part of the quadriceps would be under the rectus femoris? Vastus intermedius. Very good. So you know the four parts, and they're inserted into the quadriceps expansion, and then, right, become the quadriceps expansion, go into the patella, and then the patella ligament come down to the patella tuberosity. Remember this morning we spoke about where the tibial collateral ligament is inserted, and there are three muscles whose tendons are right over it. All right, okay? So here I have the three tendons here. All right? So we're on the medial or subcutaneous border of the tibia, right here. And I have these three tendons here dissected out for you. Who's going to tell me the names of these three muscles in the order from anterior to posterior? This one, sartorius, this one, gracilis, and this one. See, I got the wrong one in my hand. See? This one. All right? Semitendinosus. All right? So here they are. So when you see these, where these three are inserted, they are inserted right along the medial border of the tibia, right along here. Medial border of the tibia. All right, okay? And that is exactly where the tibial collateral ligament is here, and they are attached in front of the tibial collateral ligament. So they cover the tibial collateral ligament. So to find the tibial collateral ligament, you'll have to go dissecting under here, and that you wouldn't be able to see that too well. All right? So this is very important, okay? This is another thing that comes in the exams all the time. These three tendons inserted here. Anybody knows the name of this formation? There's a name that we call it. Anybody knows? Where the tree, the sartorius, the gracilis, and the semitendinosus is inserted. The pes anserinus. Who is that? Chanel Johnson. Extremely good Chanel Johnson. You've been on the board. You went to Dr. Ludenke's lecture on the thigh, right? I can see that, eh? Dr. Ludenke gives a very good lecture on the thigh. All right, okay? All right? So we can see that. All right, okay? So let us go up. Right, if we go up now, you can see that this is the vastus medialis, and this is the sartorius that's covering an area right here, right, okay, where we're going to find some vessels. Anybody knows what's the name of this area right up here? Where we find the vessels that the sartorius covers? A canal that runs between the vastus medialis and the adductors. What's the name of that canal? The adductor canal. The adductor canal. Very good. All right? The adductor canal. So if we go further up here, you can actually see that. If you look here, you can see this is the sartorius here coming up, this muscle coming right up. I haven't dissected right up. But here is you should be able to recognize the femoral artery and the femoral vein. Or, when you get up to the hospital, you're going to find they'll call those the superficial femoral artery and the superficial femoral vein. All right, okay, but this femoral artery and femoral vein that will do. All right? Okay? All right? So, while we're here then, all right, and I've had this dissected out, we want to look at the hamstrings. All right, okay? So, how many hamstrings we find laterally? Huh? And the lateral aspect, how many hamstrings? I have the 3 hamstrings here. All right, okay? All right, so here, all right, laterally is it semitendinosus, and this is which one? Chanel, you want to answer this one again? That's the other hamstring that's medially. That's medially, medially. Right. Medially is the semitendinosus and the semimembranosus. Very good. And then laterally, we were showing it earlier, the biceps femoris. All right, okay? So if we look, we'll see that what they form there is the upper, the popliteal fossa is like a diamond. All right, okay? And if I put my hand, I've dissected out the gastrocnemius head here for you, right? And I've dissected out the 3 hamstrings here for you, so you can see that diamond shape, right? Okay, where the tendinosus and membranosus are medially and the biceps femoris laterally. They form the upper aspects of the upper borders or the superior lateral borders of the popliteal fossa, and the 2 heads of the gastrocnemius. You can see them right here, right? Right? I know you haven't done the legs yet, but just to show you what is formed behind the knee. All right, okay? So that's the that is the popliteal fossa. All right. So who can tell me now what are these 3 structures we see in here in the popliteal fossa? Dissected them out for you. 1, 2, 3. In that order. Well, this doesn't look like an artery to me, right? Tibial nerve, very good. Then, what is this one? If you had them in your fingers, you'll be able to tell. Difficult unless you know it. So, what's the usual order of a nerve, artery, and vein? Right? When they're together, what's the usual order? NAV or VAN. Right? Okay? All right? Okay? But in the popliteal fossa, we go from posteriorly to anteriorly. And the 3 structures don't follow that order. Right? So what's the most superficial one? What do you think this is? Anybody? Look at it. Not the tibial nerve, but before the tibial nerve is done here. What is this? Sciatic nerve. That's a great sciatic nerve. Right, okay? And at the upper end of the popliteal fossa, it splits into the tibial nerve and the, anybody knows this one? This is the tibial nerve. What's the name of the other one? Well, common fibula, or we call it common peroneal. Any name you want, okay? Right, okay? But I like peroneal, common peroneal, and the tibial. You haven't gone into the leg yet, so I'm not going to take you there. Right, but then the next, you have done the structures as they come through the adductor hiatus, right? So what's the next one here? So the artery is superficial, the nerve is superficial, right, okay? And then the intermediate one, or posterior, the nerve is posterior. The intermediate one is the popliteal, because then the popliteal fossa, so, right? Popliteal vein. So I was saying that the order is not what you know, right? It's not nerve, artery, vein. Right? Nerve, vein, artery. One of the few places in the body where you see that, okay? You can look at this artery. So thick wall it is here, right? You can barely, whereby this I can compress easily. This is the vein, popliteal vein, and that's the popliteal artery. If I put my finger right up here, right? I'll show you something. This is the biceps femoris here, right, okay? Right? And we know that medially, we just saw the adductor tubercle a while ago on the medial condyle, right? And we said that there is a head of a part of the adductor magnus that gets inserted right at this point, right? So we have a hole in the adductor magnus here that takes it into the adductor canal. Anybody knows that aperture in the adductor magnus? What's it called? It's called the adductor hiatus, right? The adductor hiatus. So remember these two structures, right? Artery and vein, popliteal artery and popliteal vein. As they go through the adductor hiatus, they then become the femoral artery and femoral vein. The name changes at the adductor hiatus. What you're really seeing right here, this is the adductor magnus, right at that point. Right, and I'm putting my finger there to the adductor hiatus. Right, okay? All right, so that's just a little bit of the things that we're feeling. So, anybody can tell me then, what are the muscles that will flex the knee joint? What muscles will flex the knee joint? Jazan? Quadriceps? No, man. Camille. Quadriceps is an extensor, right? Right? Yes, the gastrocnemius will flex the knee joint, but what's the main flex? The hamstrings. Very good. The hamstrings. Very good. The hamstrings have two functions. Two functions. Anybody can tell me what they do? They flex the knee joint, but in order to flex the knee joint, a muscle has to be relaxed. Which muscle has to be relaxed? They extend the hip. Very good, Julian. You're doing very well. You guys are doing quite well. Right? So they extend the hip, right, okay? Right? But when the quadriceps relax, they flex the knee joint. Right, okay? Other muscles flex the knee joint, the quadriceps does, right, okay? And a couple other muscles also, right, okay? But the main flexor of the knee joint is the hamstrings, right, okay, when you're walking, right? And the extensor, main extensor, is the quadriceps femoris, all right? Very good, very good, very good. Popliteal snow, we mentioned it in the lecture this morning. What does that do? Let's show you what the popliteus is again. Right? Popliteus arises, let's go over it again. Right. In this specimen, you're not seeing the soleal line very well. It's about here. The popliteus arises above the soleal line here. Then it's going to pass through the capsule of the knee joint, running between the capsule and the synovial membrane, and then it's going to come around the lateral condyle here in this groove. And this groove is called the popliteal groove. And it gets inserted right here. Right where you see that fibers there, that's where the popliteus is inserted. Remember I said this morning, what happens when your knee joint is flexed like this, right? Okay, let's go over the mechanics again. What did I say about the shape of the condyle? Right, okay? What type of shape does this condyle have? The body a cam shape. And the cam shape means, let's the bigger bone to show it to you. The cam shape means that there's a smaller, posteriorly, this one not really, he has a lot of arthritis or something here, so I don't think you really see that too well. Right? Let's use the smaller, right? So if we look at it laterally, it's a smaller arc, the arc of a smaller circle posteriorly, arc of a larger circle anteriorly, and two straight sides. So this is a straight side. So when it's extended, there's more congruity between the two bones. All right, so the knee is more firmer. When we flex now, it's the smaller arc that contacts the condyle, so we can get some movement of the tibia on the femur. But the other thing that you have to know about the mechanics of the knee is the difference in the condyles, right? So the lateral femoral condyle is shorter and more circular. Right, just go right in here again for me. Right? And the medial, right, femoral condyle is longer and narrower. So when the knee is flexed and we extend it, right, when we get to about here, the lateral condyle has come to the end of its run. Right? So the only way that this medial condyle can move back is for the femur has to rotate and then the knee straighten, rotate medially, right? Because the medial condyle is longer, right, okay? Right, the lateral condyle comes to the end of its run first and the medial condyle then rotates back and you get straightening of the knee. And the knee gets locked in extension. Right, now, before the hamstrings can start bending the knee, look what has to happen. We have to derotate. Everybody following me? We have to derotate the knee. And this is where the popliteus comes in. Popliteus is inserted here, so it pulls on the lateral condyle like that, and it derotates the knee at the start of flexion, and then the hamstrings take over and start to flex. All right? So those are the mechanics I want to leave with you. Now let's open the knee joint and see what we see inside. All right, okay? So if we look now, all right, what we see in here is a synovial membrane. Huh? All this is synovial membrane. Very thin stuff right here. All right, okay? We look at the back of the patella. Let's look at the front of the femoral condyles first, so the patella area, right? And we can see smaller, right, again, medial surface and a larger lateral surface. That's going to fit on the smaller, right, again, medial surface here, and this much larger lateral surface of the patella. Right, okay, so they actually fits quite well. Right, okay, and this is the high patella buttress right here that prevents the patella from slipping over the side like that. You know, about 2 weeks before COVID, I just had a lab here, a large group of students. And as soon as I got outside, I was on my way to my office, and I heard this scream. This young lady who was in my lab group, she bent over and clutched her knee. Right? When I got to her, she would not even allow me to touch it. Right? She said, Dr. Francis, my patella is dislocated. So I said, how do you know that? I looked and I saw it. It was dislocated. She said, you know, it has dislocated about 3 times before. Right, okay? So she wouldn't even allow me to touch it. So we took her up to the A&E department at the university. They gave her some sedation, and they gave her some analgesia, and just slipped it back in place. Right, okay? So it's not an uncommon thing, right? This is a young female medical student, right, okay? And it happens. Not common, it's not rare either. Right, okay? And remember the factors that prevent it from happening. Sometimes, if it keeps sometimes the person, you teach the person to not to make sudden movements. She had made a sudden movement, where she had tripped, I think, over something, and that's what happened. But it doesn't happen very easily, right? Okay, something has to. So, if it gets too bad, you may have to have surgery to correct or to improve the lateral buttress there a little, right? And that's not very good surgery to have, right? So if you can get by without it, right? Okay? Right, so that's the patella. Now we're going to look, are we going to see the synovial membrane? All right, so there we go. A synovial membrane there, light right in there. Yeah, it's good, you can go down a little bit more. Yeah? All right, good, yeah. A synovial membrane there, right, okay? Right here, not here, right, okay? Right, and this is the infrapatellar fat, right here. Sort of torn away a little there, right, okay? And this is the infrapatellar fold, right? And right about here, and here and there should be lateral folds. I think I saw them better in this knee, right? So here, you can see the infrapatellar, right? Fold here, right here, and there is an alar fold here, and another one here, right, okay? If we pull off this bit a little bit here, we're going to come right down, a little bit hard, to the arm. I don't really want to destroy the knee, right? So if we go right behind these now, we're going to find the arm, the cruciate. So let me just try and show you the cruciate here. If we look right in here, right, without pulling away because remember the cruciates now, they are intracapsular, but they're extra synovial. So this is synovial membrane lining them here, right? So what we have here is the anterior cruciate coming from here, that's going towards the lateral, the lateral medial aspect of the lateral contact. And this big boy here, you can pull off this one a little bit here. Synovial membrane, yeah, right? This is this boy here, this is the big posterior cruciate, right? Coming from posteriorly, I can't show you that, right? I can only show you the image, and they cross each other like that. So this is the posterior cruciate, and this is the anterior cruciate, right? Okay? So we've done the collateral ligaments, and now we know the cruciates. The cruciates are extrasynovial, but intracapsular. The capsule goes right around the knee joint. Capsule is attached right along the edges of the articular surface, right around. There's an extension that goes up further up here, right? Okay, that's the synovial bursa, right? Right up here, right? So that's fat. Synovial bursa goes up to here, right? Comes up to about here. Anybody ever heard of a muscle called the articularis genus? Articularis genus. No? Yes? Brianna has heard about it. Brianna. Tell me where the articularis genus comes off. It's a tiny muscle that comes off of the anterior surface of the femur, right below the vastus intermedius, right here. Tiny muscle, right? Okay, and it holds up the suprapatellar bursa. It's inserted into the suprapatellar bursa, so it keeps it up there, prevent it from dropping down. Right? So those are the things that they'll ask you about. They can show you those two ligaments there. Right? But usually you get shown for the ligaments, I can assure you, right? You're going to get an image, right? Okay. So let's look some of these. Look at some of these images. Here we can see the menisci, and always remember the difference in shape between the medial meniscus and the lateral meniscus. One is about half a circle, much longer anterior posteriorly, and that's the medial. The lateral is more circular, about 4/5 of a circle, right? Here, this is the left knee. So here we have the left, the lateral collateral ligament, which is also called the fibular collateral ligament. You see how cord-like it is, right here? Cord-like. Anybody can tell me which muscle is this tendon we're seeing here? Anybody can tell me? Chernel. What is this muscle that's inserted into the fibula? Bicep femoris. Very good. Very good, Chernel. You're on the ball with the anatomy. I can see that, eh? Very good, Chernel. Right? If you have any problem, any questions at all, drop me an email and ask me questions, okay? Right? I hope you've been looking at my quizzes. Right? I have all these things in the quizzes. All right, guys? Okay? All right? Socrative, go to Socrative. All right? Student, log in and just put in the room number and give them a try. All right, okay? Mikhail, they like the quizzes, right? Very good, okay. All right, so look at the tibial collateral ligament now. Right, okay? This is the tibial collateral ligament. Right? Again, you can see how it's, unlike the fibular collateral ligament, it's attached, not just to the capsule, which has been removed. The capsule will be from here to here. Right, okay? Capsule. It's attached also to the medial meniscus. And that's why when the knee, like you're playing soccer, and you have your knee planted on the ground, right? Your knee's planted on the ground, and all of a sudden you're going for the ball, and all of a sudden somebody has kicked the ball somewhere, so you try and twist, right, to get at the ball, right? Okay, it's a twisting injury to the knee, and what that's going to do, that's going to tear. Well, first of all, it's going to put a lot of strain on this medial collateral ligament because it's attached to the medial meniscus. And that's why the medial meniscus is the most commonly torn of the two meniscus, right? Because it's attached to it. So medial meniscus tear, right? It's usually the most common injury because of this attachment, right? Now here, you can't miss this big posterior cruciate, PCL, right? It's attached right to the posterior part of the intercondylar eminence here, and it goes in to the medial the medial condyle. Right, you can see the anterior. The anterior is here. Right? Now, sometimes the player is going, right, okay, and he has his knee planted, that leg planted, the knee flexed, and he's twisting, and another player come and tackle him from the side. And that he gets he starts getting the injury now, not just of the tibial collateral ligament, but tibial collateral ligament, he also gets an injury of the medial meniscus, and the anterior cruciate goes. Right? Anterior cruciate goes. Right? So he comes to you now and you want to know if his anterior cruciate has gone. This is what you do. You put the patient lying on the bed, and he flexes his knee like this. And then he moves they try to move the tibia forward on the fibula, on the femur. Try to move the tibia forward on the femur. That's called a draw test. Draw, D-R-A-W-E-R. And if the tibia moves forward on the femur, it means that the ACL has gone. ACL has gone. If the tibia moves excessively backwards on the femur, it means its PCL has gone. Right? Remember, the ACL prevents forward movement of the femur on the tibia. Right? Okay. So if the the PCL, right, prevents forward movement of the femur on the tibia, and the ACL prevents backward movement of the femur on the tibia. Right? Okay. Right. It's femur. But if you extrapolate now for the tibia, when you're doing the draw test, right, if there's excessive movement of the tibia anteriorly, it means the ACL has gone. If there's excessive movement posteriorly, that means the femur is going to slip over anteriorly, right, okay? Then it means the PCL is gone. Right, I'll show you how the test is done. All right. So here's what you do. You just flex his knee, and if you get excessive movement anteriorly of the tibia on the fibula, so just remember, anterior is ACL, posterior is PCL. But remember, the PCL prevents the tibia the femur from going forward, and the ACL from it going backwards. All right, okay? All right. Now, I want to show you a picture here of an MRI, right? Okay, right, and I know that you're remember that injury I talked about where you get those three things go wrong. You tear your medial collateral ligament, then you tear your medial meniscus, and then you tear an ACL. And I don't know, anybody here has had an ACL injury? Anybody? Okay, all right. I think I've met 2 students over the past 8 years that have had ACL injuries from football. Right, okay, and it's a significant ACL, anterior cruciate ligament injury. It's a very serious injury, right, okay? All right, and if I show you what the normal MRI looks, this here is just showing you, right, okay, the ACL, right, anterior cruciate. You can see a normal attachment to the lateral condyle here. There we've seen a normal looking meniscus, and here's a normal tibial collateral ligament. We know that this is an MRI because the bones are grayish. If it was a CT scan, the bones would be white. Right, okay? You don't need to know this stuff. I'm just showing you this for your interest, huh? All right, okay? But if we look here now on an MRI, you can see that the nice ACL has been torn off right here. Right, okay? We see that the medial meniscus is torn right there, and we can see this nice tibial collateral ligament here has been freed. Right, okay? It's freed. It's not like that. There's more here. It has been freed. Right, okay? So we're called the unhappy triad. Right? We're talking this morning about the same things I just showed you inside. Right, okay? Where the synovial membrane now lines the capsule. Right, it lines the capsule. You never find synovial membrane on articulating surfaces. Huh? It's attached to the capsule and around the articulating surfaces. Right, okay? And not much synovial fluid is secreted. It's just enough to keep the joint to lubricate the joint. Huh? You don't want too much fluid in there. Right, okay? But the cruciates, they are intracapsular but extrasynovial. That's what you see in the middle of the knee there. All right, so I showed you the synovial membrane over the cruciates, and then I showed you the infrapatellar fat pad here, right, okay, and how it makes this fold, which I showed you a while ago. I'm going to show it to you again. That's the infrapatellar fold. And then in real life or in arthroscopy, you see it much better, the alar folds, where the edges of the fat pad. There's two more folds like that. Right, okay? Then we have all these bursae, right, around the knee, right? So you don't have to know them all, but right, remember that the synovial membrane, the synovial cavity quite often extends up on behind the attachments of the gastrocnemius, right, of the gastrocnemius here, right, okay. So this is called these are called the gastrocnemius bursa. But they're really normal part of the synovial cavity, right. But there are some other areas that they have bursa that they're pretty quiet and you don't know they have them until they get irritated. Right? So one is the prepatellar bursa right here, right in front of the patella. And if you get that inflamed, painful, swollen, you may have to go and aspirate the fluid, put them on some antibiotics, right? And if it keeps recurring, you might have to excise it. And this one is called housemaid's knee. The housemaids usually do a lot of work on their knees. Then we have the infrapatellar bursa here. All right? So if you understand those things about the knee joint, there isn't really much more you have to know. So let us just talk about some of the other stuff that are around the knee joint again and go into a little detail. All right, okay? See how much you know about the thigh. Okay, so when you're sitting, where you're sitting there right now, the ischial tuberosity here has two parts to it. This is the part you sit on, right? So this part up here, posteriorly here, this belongs to the hamstrings. So I want to ask someone, which hamstring arises from the lateral part of it? Anybody can tell me. Which hamstring? We go into the semitendinosus, semimembranosus, bifurofemoris. Which one arises here? All three arise from this area. Which one arises here laterally? Anybody knows? Take a guess. No. I take on the semimembranosus. Semimembranosus is the one that arises laterally. Semitendinosus and biceps femoris, the long head of biceps femoris, arises with the semitendinosus from the medial aspect of the ischial tuberosity. And they're going to run down the back of the thigh. Why it's so important to know this, you see? You've heard of hamstring tears, eh? You've known athletes that they've had to lose 6 months of almost a year due to a serious hamstring injury, right? So most of the hamstring injuries are just little tears, right? You pull up in the race with a hamstring. Sometimes a little tear, but sometimes a big tear. The big tears can pull out a chunk, a little piece of the ischial tuberosity with it. And those are serious tears, right, okay? They're going to take a long time out for rehabilitation, surgery, even surgery sometimes. Right, okay, so you have to know where the hamstrings are at. Right? As the hamstrings come down the back now, right, they're going to diverge. Right? Biceps femoris is going to come this way, All right, okay? All right, biceps femoris and semitendinosus, they arise laterally. A biceps femoris come down this way, and then biceps femoris, right, is going to be, this is the long head of biceps femoris, then we're going to find the short head. We can see a little bit of the short head there, right? So that's the short head of biceps femoris, right? This is the short head of biceps femoris. Let me show you this one. Biceps femoris, all right? Okay, so here we can actually not really dissect it out fully, but here we can actually see the short head of biceps femoris right up there. Where does that arise from? Okay, well, you don't have to see it. Where does the short head of the biceps femoris arise from? Anybody can tell me. Zoe Lee, let me show you again. All right, this is semitendinosus, semimembranosus. This is biceps femoris. Biceps femoris has a long head, which is the long head, this long head here coming from way up on the issue of tuberosity, and this part here, this is the short head, right? So if right here, that's the short head there. It's coming off the bone, right? So you can see it there now. That's the short head of the biceps femoris there. All right, okay, let me show you on the other bone so you can look better. This is the biceps femoris here laterally. Remember, the biceps femoris is lateral, and the semitendinosus and semimembranosus are medial. Semitendinosus is easy to see it. It's semitendon. Most of the lower part is tendon. Right? This tendon goes and is going to be inserted way down on the ischial, on the tibial, on the medial surface of the tibia. But I'm asking, where does the short head of the biceps femoris come from? Linea aspera. Who's that again? Damian Clark. Very good, Damian. Right? Excellent. Very good, Jody. Jody knows all this stuff, right? She's been through me already, so she knows all that stuff. All right, okay? The biceps femoris short head comes off of the linea aspera. All right? Now, which is the only muscle, right, in the back of the thigh that covers the sciatic nerve? Which of the three? Right? Which of these three is the only muscle that covers the sciatic nerve? Runs on over it. Sorry, I don't have a full tie to show you. No? Biceps. Which head of the biceps do we? Long head. Very good. Very good. The long head of the biceps is the only muscle if you dissect the back of the thigh. Right, okay? That is going to cover. So here is the sciatic nerve and the long head of the biceps. This is this here coming down. I'll go further up, I'll show you. Right? Sciatic nerve here, right here, sciatic nerve there, and that's the long head of the biceps femoris coming down here. That's sciatic nerve. This is the long head of the biceps femoris coming down there. Right, okay? Only muscle that covers it. Right? How far have you gotten with the thigh? All right? Have you gotten into anatomy? Have you gone into the legos yet? No, not into the legos yet. All right, okay? So you're going to thigh. All right, okay? So everybody should recognize all these things. All right, okay? These three things here, look at them again. You're not going to see these dissected out much better than that. All right, okay? Sartorius. This question goes to Joan Gaino. Where does the sartorius arise? John? Where does the sartorius arise? Zoe? Anybody? Jodianne? ASIS. Very good, very good. So the sartorius arises right here, the anterior superior iliac spine, right? So it's going to cross two joints. So it can actually flex the hip as well as it can flex the knee. Right, okay? You can flex the hip as well as it can flex the knee because it's going to go right across, it can flex the hip and it's going across the knee, and it can flex the knee a little bit, not much. Right, gracilis, right, also, it's an adductor, but you can also flex the hip a little too, right, okay? Flex the knee a little bit also, right, okay? All right, okay? All right? Now, what are the muscles that will cause, when the knee is in flexion, that will cause the internal rotation and lateral rotation of the tibia on the femur? Sure now. I'll just show that to you. The hamstrings. All right? So when the knee is in flexion, like this, right, okay, it will be the lateral hamstrings, right, okay, which would be the lateral hamstring, which is the biceps femoris, that will cause medial rotation. Lateral rotation. It will be the medial hamstrings, right, which is this one here, which is membranosus, and this one is tendinosus, and you can see the difference, huh? This is membranosus here, right? Anybody can tell me where membranosus is inserted? Semimembranosus. We know semitendinosus is inserted into the subcutaneous border of the tibia. Where is the membranosus inserted? Membranosus, semimembranosus. Another common question. Right, okay? Here, if we look at it, this is the lateral condyle of the tibia. This is the medial condyle of the tibia. All right, on the lateral condyle, we have this big area here, which is the Gerdy's tubercle. All right, okay? That's for the iliotibial tract. Right, on the medial condyle, this groove you see right here, that's where semimembranosus is attached. Right, the semimembranosus is attached here, but semitendinosus is going to go further down here. Always remember the order in which these three structures are inserted. Sartorius, then gracilis, then semitendinosus. Sartorius, gracilis, semitendinosus. So quite a lot of time in the exam, they just draw a little line here, and another line here, and another line here, and they ask you which of these four muscles is inserted there. So always remember it's say grace before T. Say grace before T. Sartorius come anteriorly. Sartorius, gracilis, semitendinosus. T is tendinosus. All right? Semimembranosus is attached here. Remember I said semimembranosus now, as this attaches here, it has three bands that come off from it. One band runs down here, covers the popliteus, and gets attached to the soleal line. Another band that goes here and is attached to the subcutaneous border of the tibia. Another band that goes up across the posterior aspect of the capsule of the knee joint and gives rise to a ligament. Ariel, what's the name of that ligament? A ligament that runs off of the semimembranosus tendon as it's inserted. It goes up and strengthens the back of the capsule of the knee joint. Ariel. Okay? Anybody at all? It's the oblique popliteal. Let's see if I have a picture to show you that. Oh. Okay? Oblique popliteal. All right, remember that? So if you put the knee joint together like that, there we have a capsule. We have a capsule across here. That capsule is going to run, right, from here all along the articular area here to all along the edge of the articular area here. All right, and these cruciates are going to be intracapsular intracapsular, but extra synovial, right? And a band from the cerebrovenosus comes up across the back of it, of the capsule, strengthens it. I showed you in the PowerPoint this morning, and then it's attached to the medial and femoral condyle. That's the oblique popliteal. Oblique popliteal ligament. From the apex of the fibula now, another band that comes up, right, okay? And then it goes like this, it has a Y shape, and again it strengthens the posterior capsule. What's the name of that ligament? Anybody remember? Arcuate popliteal. Arcuate popliteal. So remember, you have two small ligaments at the back. They're nowhere as strong as the cruciates and the collateral ligaments, right, okay? But they are the oblique popliteal. A question comes sometimes, right, okay? They'll show you the insertion right here on the medial condyle. That's the insertion for the semimembranosus. Tendinosus is right here on the. Remember, the tibia has an anterior border, a medial border, and an interosseous border. Right? Okay. This anterior border is the subcutaneous border. If you rub your hand along your shin bone, you just feel in the bone. You're not feeling the muscle. That's the medial border of the tibia right here. The upper part here now. That's where these three tendons get inserted. These three tendons here, right, that you see here, right? And there's several dissections around that have these three, not this one, sorry. That's membranosus. This is tendinosus. So you can see sartorius is inserted first. You can go right down and see where it is inserted right here, right, all the way down. Then, right, you can see gracilis. Gracilis is the most medial muscle you find on the thigh. Gracilis. Anybody knows where the gracilis comes from? Right? So we look at the pubic bone here now. We know that this is the area for the adductors. Anybody can tell me which adductor arises right here? Anybody? Which of the adductors arise right in the corner here, between the pubic tubercle and the symphysis, right here? No, adductor longus, very good, adductor longus. All right, okay? Then, which one arises along the edge here now? Now we come into what I'm talking about. What's that? Gracilis. Gracilis is right along here. You know what gracilis does? The adducts your thighs, right? It adducts the thigh, right, okay? And it medially rotates the leg. So it's called the anti-rape muscle. Anti-rape muscle. If a woman doesn't want to be raped, she just contract the adductor. Nobody ever have that experience. Contract the gracilis, right, okay? And the gracilis is going to adduct your thigh and medially rotate it, right, okay? Right, so the adductor comes off of here. The gracilis comes off of here. So remember, the gracilis is an adductor, right, okay? And you can see it's called gracilis because look at the tendon. Very, very, very fine tendon here, and it's used for tendon transplants, right? Right? That helps to remember it. Okay, all right. I would tell you which one is the honeymoon muscle, but I wouldn't go there. That's the one that helps you to open your thigh and laterally rotate it. That's the sartorius. The sartorius is the one that says. Remember, the sartorius is called the tailor's muscle, right? Tailor's muscle, right? The tailor, when he sits, he has his hip flex, thigh externally rotated, right? Okay, and abducted, right? Okay, so that's sartorius, right? Okay. Then we have a big muscle now, big one, which has a condylar head, arising from the ischial tuberosity, hamstring head, sorry, arising from the ischial tuberosity, and a adductor head now arising along here. Long origin, that's the adductor magnus. That's the adductor magnus. Right, that's the adductor magnus. Right, and right here now, inside them all, on the longus will be what? Brevis. Very good, brevis. And you have one more adductor muscle, which is not really listed sometime in the adductor, which arises right here, from this line. This line. This is the pubic tubercle. The pubic tubercle here has two lines radiating from it. One going here, right, okay, which is going to form part of the pelvic brim. Right, this is it. What line is this? Anybody knows the name of this line? The sharp line right here. It has a muscle with the same name. It's an adductor as well as a flexor of the thigh. Pectineus line, right? The pectineal line of the pubic bone, right? That's right along there. Anatomy is interesting here, but you have to think about it, and you have to look at the bones, and that's why I feel a little bit, sorry, because we don't have small tutorial groups where I can take you guys through all this other thing, eh? Because just reading it alone, you can never learn it. So what I say you should do is form small. You feel robbed? No. When you get to the clinical medicine, then you're going to, right? Then you're going to. I know, but COVID has robbed people of a lot of things. Eh? We're really trying our best to help you here, and I'm here for you. Anything at all you want to ask me, drop me an email. Right? Okay? All right? Seriously, that's one of the reasons I put out the quizzes, because I've shown every quiz has a dissected specimen in it. I've gone through the bones in the quizzes, right? All these things are in the quiz. All these things I just showed you here. All right, okay? All right? So remember that the adductor magnus now has a hamstring part and an adductor part. Right, okay? So the part that arises from the ischial tuberosity is the hamstring part. And that's the part that gets inserted into this tubercle right here. Right? This tubercle, we call this tubercle. What's the name of this tubercle? The adductor tubercle. That's a hamstring head. It's also called the condylar part, because it goes to the condyle of the femur. Right, okay? So what nerve innervates that part? Yeah, the adductor magnus has two innervations. What nerve innervates the condylar part? No. Condylar part is the hamstring part. Well, the sciatic. Which part is sciatic? Tibia, right? Tibia nerve, right? Okay? Right? The part that the common fibula innervates is the short head of the biceps femoris, right? Okay, the tibial part, and then what nerve innervates the adductor part now? The adductor part is inserted all along the linear spur. Right? Very good, Julian. Oh boy. Posterior division of the obturator nerve. Very good. Excellent. Right? Posterior division of the obturator. So which muscles does the anterior division innervate now, Julian? Mary? Posterior innervates one nerve, really. Sorry, one muscle. And that's right, remember the posterior goes through the obturator externus, so it gives a innervation to the obturator externus, and then it runs down behind the brevis and behind brevis and longus, and innervates the adductor magnus. But the anterior now doesn't go through the obturator externus, it runs down in front of brevis, right, okay, but behind longus, and it innervates brevis, longus, and gracilis, right? And it also gives a cutaneous branch to the medial aspect of the thigh, right, okay? All right, so very good, yeah. You guys are doing pretty well, all right? Anything else you want to see on the knee? All right? You want me to go over these things inside here or not? Which cruciate ligament are we seeing? Right here. So this is the infrapatellar fold, right? Very good. That should be better in this one, right? That's the infrapatellar fold. It was connected here, right? So there's the infrapatellar fold, and this is synovial membrane is seen here, guys. This is the fat part, and the reason they think these fat parts are put into joints is to increase the surface area of the synovial membrane, right? Okay, I think it fills out space too between the tibia and the patellar ligament, right? Okay. And it has an alar fold on one side, a wing, and another wing here. Then if you go behind there now, right? Pull it off. It's coming off. Put it off there. Okay, there we go. So that's the sign of a membrane comes off a little bit more here. Right? Now we start seeing, right, the cruciates. Right? So this cruciate here, right? And we'll be the anterior cruciate will be going to the lateral, this one here. The posterior cruciate will be right here, this big boy. We'll go to the medial. Right, okay? The medial. The posterior cruciate here, this big boy here, and this smaller one here, the anterior cruciate. Right, okay? And they are very important for anterior posterior stability of the knee. Very important for anterior posterior stability of the knee. Right, okay? And to find out if they're ruptured, if you do draw test, just try to draw the tibia forward on the femur. Right? Let me just ask some questions now. This one here. Anybody knows this vein? What vein is this? This is the lateral aspect, right here. This is the medial aspect. What vein is this? Big vein here. Starts down at the medial malleolus, so you don't know where it starts, but you must have seen it in the thigh, right? It run. When I sometimes I have to remove it because it becomes varicose, right? Okay, I know exactly where to find it. I go, look what I do. I get one hand's breadth behind the edge of the patella, right here, and look at that. So I know exactly as a surgeon where to cut down and find it, right? Because sometimes when this becomes varicose, I have to remove it, right? Okay, right? So I make a small incision above and a small incision below, pass a stripper and I strip it out. But sometimes the stripper doesn't really go all the way, so I have to go down to get it, right? Okay. So I know exactly where to run. Look at me, one hand's breadth, right? Okay. This is the edge of the patella, behind the patella. Right? Okay, there you see the vein, which vein is the great saphenous. Very good, Raheem. You've been answering a lot of my questions. Very good. Excellent. And when you come to do the leg this week, you're going to find that it starts It starts from the medial, right, okay? There's a dorsal venous arch of the foot. It starts from the medial side and it's going to come run at about 2 centimeters in front of the medial malleolus. So you just put your finger on the medial malleolus there, and you can cut down and you can find it. But every time you're doing that, right, you have to look for something. Anybody can tell me what you have to look for? From this yesterday, so I need to find it again. Here we go. Who can tell me what this is? Another exam question. I know you haven't done the leg yet, but you've done the thigh, and you should know what this structure is. Raheem, what is this structure? Runs with the great saphenous vein. Look at it. Why I'm doing all this is because I know you're not going to get a chance to see too many specimens. So I think we've done enough on the knee. I don't think you really need to know much more about the knee. In terms of, you have to know the genicular anastomosis, but that's not really the knee joint. That's between the vessels. Saphenous nerve, very good, Benito. Right? So what nerve is it a branch of? Benito, I'm sticking with you. Which nerve is the saphenous nerve a branch of? I want a guess from Benito. Oh, that was a guess. Okay, all right. Which nerve is it a branch of? Ephemeral. Very good. Atia McGee. Right. What are the three, now McGee, Atia, you have to answer this question now. What are the three cutaneous branches of the femoral nerve? What are the three cutaneous branches of the femoral nerve? What are the three? You went to Dr. Lodenke's lecture? I'm certain he told you. He told you about the SIM card. Did Dr. Lodenke mention the SIM card? If he didn't, then he's slipping up because he's the one who invented that mnemonic for the three cutaneous branches of the femoral nerve. Saphenous, intermediate cutaneous, and medial cutaneous. So as the saphenous comes through from the thigh, this is the lateral, the lateral cutaneous belongs to the lateral cutaneous nerve of thigh. There's a separate nerve. By the way, Thursday morning, I'm doing the lecture with you on lumbosacral plexus. All right, okay? I'm coming to it. All right, okay? So the lateral cutaneous is a separate nerve. That's a branch of the lumbar plexus. And that's for Thursday morning. There's a lot of things left to do now, guys. All right, okay? The saphenous, the femoral, which supplies all these muscles in front here, right? Quadriceps, the sartorius, the branch of the pectineus, the four quadriceps, right? Okay, right? It also has three cutaneous branches. So it gives off an intermediate cutaneous, which supplies the intermediate part of the thigh. So this is the anterior thigh here, right? It gives off a medial cutaneous, right? Okay, so intermediate cutaneous, medial cutaneous nerve of thigh, intermediate cutaneous nerve of thigh. And it gives off the saphenous. So those are the three cutaneous branches of the femoral nerve. Right, okay? Saphenous, right? Intermediate cutaneous and medial cutaneous. SIM, SIM nerve. Very good, Jody. Very good. Right? Right? So SIM nerve. So this, you see, things that you get in the exams, the things that you can see, you can recognize. That's the saphenous, that's the great saphenous vein there, right? And this is the saphenous nerve. Now, how does the saphenous nerve get here? Anybody can tell me? What does it have to run through? What canal that runs through the side? Jodianne, you know. It runs in the side with a big artery and a big vein. The adductor canal. Very good. It goes through the adductor canal, right? Okay. So the four things in the adductor canal is the femoral artery, femoral vein, the saphenous nerve, and the nerve, and the femoral branch, to the vastus medialis. Very good, Jodianne, very vastus medialis. Very good. You guys are on the ball. All right. Now I'm just going to show you one last one, and what's the name? Shanique is telling me it's time to go. Shanique? 3:48, we saw this over. All right, okay? All right? You know I can talk about anatomy all evening, right? So let's find this little one there for you. All right? Okay. This one now, who can tell me what this is? What vein are we seeing here? Huh? I know you haven't done this high yet, but if you do one here and it's great, what is this one? Huh? Take a guess. Small, right? It's also called lesser, right? Lesser cutaneous. Or small saphenous is also another name, but lesser cutaneous. So there's a great, there's a lesser cutaneous. Now where does this one drain out? This one is going to drain into the popliteal vein. Right, so it's going to go right through the popliteal fossa into the popliteal vein. Right? Now where does this boy go to? Who's going to tell me where this goes? Small? Yeah? Some people call it small or lesser saphenous. Right? So great saphenous and small or lesser saphenous. Right, okay? Right? And this greater saphenous, where does this drain into? Cherise. Greater saphenous. You've done the tie already. Drains into the femoral vein. Right, okay? It drains into the femoral vein where? Right? It has to go through a fossa called the fossa what? Fossa ovalis. Fossa ovalis, so that's the saphenofemoral junction, right, okay? You've got to drain through the fossa ovalis, right, which is right over the femoral triangle, right, okay? The fascia, the fascia lata has a small area there called the fossa ovalis. It's an oval-shaped fossa. This is going to drain through it. And that oval-shaped fossa is covered by a fascia called a cribiform fascia. Right, okay? And this pierces that cribiform fascia and goes into the femoral vein up there. The other question they're going to ask you, the guy that loves that question. Right, okay? What's the surface anatomy, right, of the where the greater saphenous goes up to saphenofemoral junction? Right? Anybody knows? So this, we have to relate it to this point. So when I'm doing a varicosity of the great saphenous, I have to make a incision up here, right? Okay. So I need to know where the saphenofemoral junction is. I relate it to pubic. Right? It's 3.5 centimeters down and laterally. 3.5 centimeters inferiorly and laterally. Right? 3.75 centimeters. Okay? Or 1.5 inches, I think it is. Right, okay? Last says. Anybody have any questions? Did I go through two things too fast, or did you like this type of review? You like this type of review where I sort of went outside the area a little? No, I was asking you where is the surface anatomy for the saphenofemoral junction. Right? Because that question comes. We saw this greater saphenous vein here. This greater saphenous is cut here now. It's going to run right up the medial aspect of the thigh. It is coming up here. Right? It runs in the superficial fascia, so it's outside. This is the fascia lata. Right? Right? The fascia lata is going to run in the superficial fascia till it gets up to the. Remember that the femoral triangle, right, is up here because inguinal ligament runs from here to here. Right? Okay. Right? So the femoral triangle is up here. So where the great saphenous joins the femoral vein is the saphenofemoral junction, 3.5 centimeters inferiorly and lateral to the pubic tubercle. Right, okay? Or inch and a half. All right? One last thing about it. Just wanted to show you what's the difference here now between this. This is the, everybody recognizes the structure on the lateral aspect of the thigh. What is it again? Just remind me again, what is this called? Lateral, so this is the lateral aspect of the thigh, iliotibial tract. And Chanel, where is it inserted in again? The more you keep repeating it, Gerdy's G-E-R-D-E-S, G-E-R-D-Y-S, right? Gerdy's tubercle. I see how thick it is. Right, okay? Look at the rest of the fascia lata. This is fascia lata. This is about what the fascia lata looks like. You can see through it, eh? Right? The light is shining through it there, you can see. Right, sorry, here. Right, okay? But look at this. It's thickening of the fascia lata. And if you follow it deeper, you're going to come across, right, the lateral intermuscular septum. Let me show you this one. Okay. All right, so here, you follow this, you're going to find the lateral intermuscular septum. All right, so here's the lateral intermuscular septum. I think I showed it better in this one. All right, come in here. This is the only significant septum you can really feel in the lateral intermuscular septum. Right, okay? So tell me now what are the two muscles on either side of it. Anteriorly here, everybody knows this muscle, right? This is the lateral, right? So everybody knows this muscle. What is this? This is the thigh, this is the quadriceps, and this is laterally. Anterior, which muscle? This muscle. Vastus lateralis. And posteriorly now, what am I seeing there? We look here, I'll show you. Right here, you can see the lateral intermuscular septum. You can see it here? You can see it? Right? So it runs from the inner aspect of the iliotibial tract, and it goes in and it separates the hamstring compartment from the extensor compartment. So the muscle in front of it is the vastus lateralis, and the muscle behind it is what? What do I have here? What muscle is this? Laterally. Laterally. Underneath. What muscle is this? The hamstring. And the lateral aspect of it. So here, medially we have the semimembranosus and semitendinosus biceps femoris. This separates the vastus lateralis from the short head of the biceps femoris. So it's the short head. All you see going up there, that's the short head of the biceps femoris, which is coming off of the linea aspera. All right? Always remember that the lateral intermuscular septum separates the hamstring compartment from the anterior compartment. Right, again, and the muscle in front is the vastus lateralis, the muscle behind is the short head of the biceps femoris. Well, guys, I think we've covered a lot today. Anybody have any questions before we go? 4 more minutes. Anybody have any questions? One last question. Anybody at all? I know you guys will be tired. You've had a long day. All right. The name of the septum is the lateral intermuscular septum. You have a lateral intermuscular septum, You have a medial intermuscular septum, and there isn't really much of a posterior intermuscular septum. Remember, there are three compartments in the leg, in the side. There's a hamstring compartment behind that's separated laterally, right, okay, from the anterior of our extensor compartment by the lateral intermuscular septum. That's the most significant one. There's another septum that separates the extensor compartment from the adductor compartment. There's the medial intermuscular septum. That one is not, it runs through the adductor canal, and that one is not really that much of a septum. You don't see, the most significant septum you see is the lateral intermuscular septum. All right? Okay, guys, have a good day. All right, okay? All right, thanks a lot, Shania. All right, any questions, keep them coming. Drop me an email. Quite a few of you have done that. Send it to my email address or to my Gmail address, anyone. All right.